Ladies and gentlemen, now we are moving towards the concluding plenary session. Less is more. Is hypofractionation the new normal? I kindly invite Dr. Tushari Hapwaraj, Consultant Clinical Oncologist, and Dr. N.J. Kumaran, Consultant Clinical Oncologist, to proceed with the final session.
Good morning, UK colleagues, and good afternoon, Sri Lankan and Faro members. There's a time difference there at the moment. So now we have come to the last session, concluding plenary. It's my duty to introduce Professor Ananya Choudhury. You all know her because she has taken part in the pre-Congress as well. So Professor Ananya Choudhury is Chair and Honorary Consultant in Clinical Oncology. Professor Choudhury graduated from Trinity College, Cambridge, but undertook her clinical oncology training at the Yorkshire Deanery from year 2000 to 2008. Between 2005 and 2007, she was a chair. She was a Cancer Research UK Clinical Training Research Fellow and undertook her PhD at the University of Leeds and Princess Margaret Hospital in Toronto, Canada. For her PhD, she studied the molecular epidemiology of DNA double-strand break repair in bladder cancer and the use of systemic agents for enhanced chemosensitivity and radiosensitivity. She has a lead role in education and training for specialist registrars and clinical fellows. She joined the Christie in 2008, specializing in urology and sarcoma, and has a strong interest in translational research. In 2013, she decided to focus on radiotherapy-related research in prostate and bladder cancer. She is a clinical lead for advanced radiotherapy, including the MR-LINAC project, and is co-group leader of the Translational Radiotherapy Group within the Division of Cancer Science. Professor Choudhury currently undertakes research which aims to optimize and personalize radiotherapy using the technique or imaging technology to deliver high doses of radiotherapy while preventing the side effects to the normal tissue. And the topic she's going to do is less is more. Is hypofractionation the new normal? It is actually the current setup and practical way. It is a very important topic. And earlier we thought it's the hypofractionation is only for the palliative setup, but nowadays it's coming up for the curatives and to solve a lot of clinical practical issues. Over to you, Professor Ananya.
Good afternoon, everybody. Thank you very much for inviting me once again to the Sri Lankan annual meeting. It's always a great pleasure to meet colleagues over there, and I'm just really sad that I can't do it in person this year. Hopefully next year things will be different. So here I am virtually, and I've been asked to talk about hypofractionation. Is it the new normal, and is less more? And hopefully over the course of the next few minutes, I'm going to be able to convince you of both those things. Here are my declarations of interest. The world has changed significantly in the past 9 months. This is a map of COVID-19 infections per 100,000 of population from the 2nd of November 2020. I'm over here in this very dark brown area of Western Europe, where we've had lots of infections, and our management of the pandemic has definitely been less successful than over here, where Sri Lanka is, where I think there has been an amazing effort to control and combat the pandemic. And there's clearly much that we can learn in Western Europe about how to do these things better. But on the back of this, we have had to think a lot about our current cancer management, definitely in areas of high infection rates, but there are certainly lessons that we can learn for when the pandemic is over. Back in March, I was approached by some colleagues to be part of a publication looking at how we should treat prostate cancer in light of COVID-19. Colleagues came up with this framework to try and take into account the impact of the pandemic, how we needed to behave with new COVID secure rules, and what this would mean for departments and patients. And with this in mind, they came up with the RADS framework, an acronym that encompasses the things that we should do to make sure that not only are departments and patients safe, but that we can be efficient and maintain appropriate treatment despite the increased pressures on our workload. So we talked about remote visits, the use of telemedicine and trying to reduce face-to-face visits whenever possible, how we should be critical in our decision making and avoid radiation where there was little evidence that it was of benefit, and that when we make our decisions we should be clear on the basis of which we are providing treatment. Where possible, we should defer radiation so that if it is safe to do so, patients can be treated once the high infections or high waves of the pandemic are over, without any detriment to their cancer outcomes. And we should shorten radiation and therefore try and deliver protocols and radiotherapy which is given in a short period of time, and this is where hypofractionation needs to be considered. So is this the return of hypofractionation? Well, I'm hoping to convince you that it is, and actually for some of us hypofractionation has never really gone away. The basis of many of the protocols that we use in radiotherapy, I would suggest, is a traditional dogma and based on intrinsic radiosensitivity. What we would say is that we would use the linear quadratic model of cell kill as the underpin many of the protocols that we use, and these curves are very familiar to all of us who practice radiotherapy. As you can see here, the green curve represents tumour cells with a high alpha-beta ratio, and it's linear in its description, whereas the blue curve presents cells with a low alpha-beta ratio, and it's much more quadratic in shape. At low doses, there is less cell kill for tumours which have a low alpha-beta ratio. As you can see here, there's more cell curve with a high alpha-beta ratio. But as the dose per fraction increases, then there is increased cell kill in tumours that have a low alpha-beta ratio compared to those that have a high alpha-beta ratio. And it's this that often represents, it's this theory that often represents how we prescribe radiotherapy. So much so that prostate and breast cancers, which it is now accepted have a low alpha-beta ratio, are often treated with hypofractionated schedules, whereas, for example, bladder and head and neck cancers that are thought to have a high alpha-beta ratio are often still treated conventionally. But is this dogma? And should we be changing things based on the clinical evidence? Because there are other radiobiological factors at play. There are 5 R's of radiobiology. There's repopulation, reassortment, reoxygenation, and repair. And all of these different radiobiological factors actually interplay with cellular biology in a complex way. None of the R's of radiobiology are solely linked to one part of the biological mechanisms that underlie cells, and therefore it is complex. And the interplay of all these factors and more is actually what underlies how effective our radiotherapy protocols are. There are distinct advantages to hypofractionation. As I've suggested already, where a cancer is thought to have a low alpha beta ratio, there is a clinical benefit as there is more cell kill per dose of radiation. It automatically incorporates acceleration and therefore reduces overall treatment time and potentially reduces repopulation by virtue of treating a cancer in fewer fractions over a shorter period of time. And because it involves treating with fewer fractions over a shorter period of time, it is cost effective. And therefore, in the current climate where everybody is concerned about the economics of our countries going forward, it has distinct advantages for cost effectiveness. The disadvantages are that there's always been a concern over late normal tissue toxicity. But there is actually level 1 evidence out there that late toxicity is not an issue. The evolution of modern radiotherapy has also allowed us to be able to deliver hypofractionation, maybe in tumour sites and in situations in which we would have felt more cautious before. Over the last 50 years, we have moved from treating patients with very simple radiotherapy techniques to an era whereby we can think about using image-guided radiotherapy, intensity modulation, combining imaging such as MR and PET-CT in our plans, to stereotactic radiotherapy, protons, and even MR-guided radiotherapy. And while it is not essential to use any of these modern techniques when delivering hypofractionated radiotherapy, for some of us, the fact that these techniques exist means that we can treat with larger doses per fraction of radiotherapy more confidently. So let's start with breast radiotherapy, for example. There has been a clear evolution of breast radiotherapy. This is a diagram showing the various UK-based trials that have led us to where we are today in 2020. And as you can see, it has taken over 30 years to get to where we are through the START trials that started to reduce the dose per fraction and test moderately hypofractionation against conventional radiotherapy, through the import trials, and now to Fast Forward, which was actually published earlier this year. So the start of hypofractionated breast radiotherapy, the idea here from my colleagues was to test whether more than 2 gray per fraction was better than 2 gray per fraction. And as you can see here from the original publication, there was a clear steer that 40 gray in 15 fractions was as effective as 50 gray in 25 fractions. And not only was it as effective when it came to overall survival, but as you can see for disease-free survival, it was actually superior. And if you look at the forest plot, there is no group in which conventional radiotherapy is superior. And therefore, certainly in the UK, this became the standard of care. Some of our global colleagues were concerned about late toxicity and therefore wanted to hold back. But I think all of us who have grown up using 40 gray and 15 fractions as adjuvant radiotherapy for breast radiotherapy felt very comfortable in continuing to do so. So we fast forward to 2020, and this paper was published earlier this year, in fact, in the middle of the pandemic in May. But Certainly in the UK, we had sight of the data prior to this, and therefore, as we were going through the first wave of the pandemic, we actually felt that there were groups of patients in which we could reduce our hyperfractionated protocol from 40 and 15 gray to 26 gray in 5 fractions. And as you can see here from the local recurrence data from the trial, there is no significant difference between either 40 gray in 15 fractions, 27 gray in 5 fractions, or 26 gray in 5 fractions. And the non-inferiority parameters are met. Therefore, 26 gray in 5 fractions should be considered the standard of care in select patients. In prostate cancer, the Hypo-RT PC trial was published last year in the Lancet. This compared conventional fractionation of 78 gray in 39 fractions with 42.7 gray in 7 fractions 3 times a week. And as you can see here from the disease-free survival graph, that there's absolutely no difference in the outcome between these two fractionation schedules. What's most interesting about the Hypo-RT PC trial is approximately 7 out of 10 men treated within this trial were treated with 3D conformal radiotherapy, and therefore doses like this can be delivered without necessitating IMRT and very advanced techniques. This means that this sort of radiotherapy can potentially be delivered in any radiotherapy centre anywhere in the world. And clearly giving treatment in 3 weeks compared to giving treatment in well over 7 weeks is incredibly advantageous for patients, whether they live near or far from a radiotherapy centre. In the UK, we had the CHIP trial, which is now a few years old, and compared 74 gray in conventional fractionation to 60 and 57 gray delivered in 3 gray per fraction. And as you can see here from the biochemical failure-free survival, there's absolutely no difference between any of the schedules. However, from a non-inferiority point of view, only 60 gray in 20 fractions reached the non-inferiority endpoint, and therefore this led to 60 gray in 20 fractions being adopted as a standard of care throughout the UK. Last year, the PACE study was published, which compared conventional fractionation with stereotactic ablative radiotherapy, 36.25 gray in 5 fractions, given on alternate days. And as you can see here from a toxicity point of view, it's pretty much as you'd expect. The patients undergoing hypofractionated radiotherapy get toxicity earlier than patients undergoing conventional fractionation, but by the time patients are out to 18 months, there's actually no difference in the curves at all. During the pandemic, a number of centres, on the basis of this data and other data published about stereotactic ablative radiotherapy of the prostate, actually have moved to delivering SABR prostate to men with low and intermediate risk prostate cancer to try and reduce footfall and pressure on the department. So SABR prostate is coming, even if it isn't here already. And certainly 60 gray and 20 fractions should already be the standard of care. But where do we go next? There have been discussions to see about whether we should be looking to reduce the number of doses further. Can we treat prostate cancer in less than 5 doses? Well, our brachytherapy colleagues already do that. There's low dose rate brachytherapy for low risk patients, and there's high dose rate monotherapy given in 2 doses for patients with intermediate risk prostate cancer. So one of the questions we have is, can we actually mimic brachytherapy treatment using a linear accelerator? And SABR is as good as conventional fractionation in lung cancer. As you can see here in the SPACE study, there is actually no difference in outcome between patients treated with conventional radiotherapy or stereotactic radiotherapy out to 36 months after randomization. This is a small study, and therefore any conclusions we draw are limited, but given the fact that SABR is a standard of care in patients who have small lung tumours when compared to surgery, this is certainly something that can be considered and is being considered in higher risk patients during the current climate. And then we come to radiotherapy in bladder cancer. Bladder cancer is interesting, as conventional wisdom tells us it has a high alpha-beta ratio. And certainly in the UK, for many, many years, we have been giving treatment using 64 Gray and 32 fractions, or 55 Gray and 20 fractions, according to clinician choice. Because of this difference of opinion between clinicians, both Beacon and BC 2001, the 2 largest randomized controlled trials for bladder preservation, allowed both conventional fractionation and moderate hypofractionation within the protocols. There was no randomization because those of us who feel that our treatment works did not want to change treatment, and therefore centres declared up front which protocol they wanted to follow. And this has allowed us to actually compare 64 Gray and 55 fractions for bladder cancer. This year, an individual patient data analysis has been done. Both trials have been updated so that outcome is now out to well over 5 years in both studies. And prior to doing any analysis, it was agreed that the 95% confidence intervals should include a non-inferiority margin set at 1.25. And here are the results. If you look at this forest plot, it's very clear that not only is 55 in 20 non-inferior to 64 in 32, as you can see here for both BC 2001 and Beacon, both invasive local regional control and overall survival, the 95% confidence intervals for 55 in 20 are to the left of the non-inferior margin. But probably more importantly, for invasive local regional control, when we look at the combined population, 55 in 20 is actually better than 64 Gray in 32 fractions, with the confidence intervals lying below 1. This means that with a hazard ratio of 0.72, almost a third of patients benefit with a hazard ratio of 0.72. There is almost a 30% benefit of giving radiosensitization with 55 Gray and 20 fractions when compared to conventional fractionation. And what was interesting as well was that this benefit was also seen in radiotherapy patients alone, with a very similar hazard ratio. This consistency suggests that this isn't a random result, it's a true result, and therefore I would suggest, in fact I would recommend, that 55 gray and 20 fractions becomes the new standard of care for bladder cancer, if it isn't already. The most interesting part of this result was the fact that colleagues hadn't predicted this. And there was always the concern about the effects of toxicity with 55 gray and 20 fractions. But what we saw in the meta-analysis as well is that there was no difference in toxicity. Why should this be? Well, we can postulate all sorts of reasons, but I think this is an excellent example of the interplay between the radiobiological factors. Up until now, we've always talked about radiosensitivity and alpha-beta ratio being important. In bladder cancer, it may be that repopulation is more important, and therefore overall treatment time has a greater effect when compared to dose per fraction. There are a number of other tumour sites in which we can treat with hypofractionation. 55 in gray and 20 fractions has been used in many centres in the north of England. Head and neck cancer, lung cancer, esophageal cancer, and there are retrospective series showing that there is acceptable toxicity even if these regimens have never been compared directly with conventional treatment. Hodgkin's lymphoma is currently being treated in 27 gray and 9 fractions, and non-Hodgkin's lymphoma is being treated with 25 gray in 5 fractions. And both these protocols, although not having a lot of evidence, have been accepted by international groups of experts. And in CNS, we have long been treating patients either with poor performance status or when we have difficulties with resources, with 40 gray in 15 fractions or 30 gray in 6 fractions. So there are a number of sites in which hyperfractionated regimes are standard of care. And currently, during COVID times, we are using these fractionation schedules, but I think we need to consider whether we should use these fractionation schedules long term. So in conclusion, less is more. I think I've shown that clearly, especially with the bladder cancer data from the meta-analysis of 2 randomized control trials updated and combined together. There is actually decades of evidence showing the efficacy of hyperfractionation. And I think it's important for us as clinicians to acknowledge that, because not only is hyperfractionation effective, it is convenient for the patient, it is efficient for a department, and perhaps in the current climate, most importantly, it is cost effective. Hyperfractionation is normal, and it's here to stay. Thank you very much, and I'll take any questions.
Thank you very much, Professor Choudhury, for that very informative and excellent presentation on the timely topic. Less is more in this new normal life. So it's very useful topic to have a second thought when we are facing this pandemic with the trying to get this new normal life. So thank you so much for your excellent presentation. There are a lot of questions coming in the audience. I will try to put one by one. Are you okay with that? Shall I read the questions? Prof. Choudhury?
Yes, of course. Good morning.
Good morning. Very good morning to you. Okay, first question. Hyperfractionation in relation in children has not entered mainstream conversation. Do you think, with regard to long-term toxicity in mind, current evidence base is not robust enough to use hypofractionation in children in a major way. What do you think?
I think that's a really interesting question. Thank you very much. It's always going to be difficult in pediatric patients to make a leap from what everybody's used to, what we know works, and where we're very aware of what the late toxicity implications are. Certainly in the adult patients, there is no indication that late toxicity, certainly with pelvic radiotherapy, where we now have long-term data in both prostate and bladder to say that late toxicity is any worse in the patients treated with moderately hypofractionation. What level of evidence is required before colleagues feel that it's safe to try in pediatric patients, I guess, is a question for the pediatric community. But I think it's interesting. I would like to see maybe some discussion of this in colleagues, but I suspect it may be too difficult to actually propose randomized controlled trials to test hypofractionation.
Okay, thank you. Are there any groups of patients in which hypofractionated breast radiotherapy is not recommended?
So certainly during my training and in our practice in Manchester, we are comfortable treating all breast cancer patients with moderately hypofractionated radiotherapy. So our standard of care in low risk and in advanced breast cancer patients is 40 gray and 15 fractions, and then we would boost any other disease on top of that.
Okay.
The fast forward regime was in low to sort of locally advanced breast cancer patients at G3. And I think for those patients, it may be that while we're waiting for more long-term outcome, that colleagues feel less confident in treating that fractionation in the more advanced cases.
Okay, thank you. Can SBRT be given for high-risk prostate cancer patients? Any evidence for it?
There are retrospective series or single center cohorts published that have treated T3, T3B patients with stereotactic prostate radiotherapy, but there isn't any randomized control evidence yet from the likes of PACE-B because it didn't include those patients. In the UK, we have opened PACE-C, which is allowing us to recruit the higher risk patients to prostate saber, so we will get some evidence for that. And certainly within the Swedish trial, the Hypo-RT-PC, there were T3 patients included. So certainly in the UK, it's not a standard of care. We're recruiting into a study. I think around the rest of the world, when you talk to colleagues, it's really on a patient-by-patient basis, taking into account the risks and benefits for that individual. And I think during the pandemic, a number of colleagues may well have moved to using stereotactic prostate radiotherapy in groups of patients outside of the evidence base.
Okay. Is it possible to combine hypofractionated radiotherapy and breast boost?
Well, we do that with 14 regularly. So yes, we do.
Okay. So if hypofractionation used in prostate cancer, what is the method do you recommend for treatment verification?
So a lot of centers use daily image-guided radiotherapy using either soft tissue matching on cone beam CT, or if fiducial markers have been placed, then it doesn't need to be soft tissue matched. But actually, a lot of people have also used the standard imaging for days 1 to 3 and then weekly afterwards if there's no cause for concern. Certainly in the UK, our experience has been predominantly with cone beam CT, but other non-cone beam CT methods can also be used.
Okay, a lot of questions are coming in. Can hypofractionation be given if you are also treating the pelvic lymph nodes in prostate cancer?
We are used to using moderately hyperfractionated radiotherapy for lymph nodes. 44 to 46 gray in 20 fractions has been used very safely over a number of years, and I don't think there's any cause for concern there. And certainly our standard would be 44, 45 gray in 20 fractions to the pelvic lymph nodes, with 60 gray to the prostate. Saber lymph nodes is an area of interest, and there are some single center cohort studies published showing that it is safe to do so. So treating Saber prostate to say 36.25 gray in 5 fractions and pelvic lymph nodes to 25 and 5, but this hasn't been tested in a randomized controlled trial as yet.
Okay, thank you. Have you observed significant acute toxicity in hypofractionation schedule used for breast cancer during this pandemic?
By significant toxicity, if we're talking about grade 3 and 4, no, that's very rare. What is very clear from all of the studies in hyperfractionated radiotherapy is that the acute toxicity comes earlier, as you would predict. But then compared to conventional radiotherapy. But if we look at 6 to 12 months out from delivery of treatment, then there's no long-term toxicity differences between conventional and hyperfractionated radiotherapy.
Okay. Should we apply those constraints given in each hyperfractionation trials to evaluate plan, or should we calculate it into conventional doses when we do hyperfractionation?
When we're using hyperfractionated schedules that have been well evaluated in prospective randomized controlled trials, then I think it makes sense to use the dose constraints that are published within those trials. You know, that data is readily available. It's clear what the outcomes are based on that data, and I don't think there's any need to try and convert those dose constraints to a 2 gray per fraction equivalent.
Okay, a few more to go. At the beginning of the lecture, you have mentioned you were looking for a situation where we can defer radiation due to current pandemic. Can you give any example of such situation?
Certainly in our centre, the 2 groups of patients in which we deferred treatment were the low-risk breast cancer patients, where again there is some evidence that if you select patients carefully, small tumours, low risk of recurrence, that radiotherapy can even be avoided. So we deferred groups of those. And then actually the prostate cancer patients, the patients with low intermediate risk prostate cancer, we decided to commence active surveillance until the first wave of the pandemic was over. And in the men who had higher risk prostate cancer, for whom we were giving hormonal therapy as well as radiotherapy, we prolonged their hormonal treatment until the first wave of the pandemic was over before starting their radiotherapy. Certainly, we spent quite a lot of time looking at all our different patient groups and protocols and trying to be very clear as to the risk-benefit related to the pandemic versus the efficacy of the treatment. So where we felt there wasn't a significant advantage to, for example, neoadjuvant chemotherapy, we omitted neoadjuvant chemotherapy and went straight to radical treatment.
Okay. This is a question regarding perception. How about the compliance of medical community? How about the compliance of the patients? Because patients may compare treatment schedule among similar patients if you try hyperfractionation compared to conventional.
So a lot of patients actually are very, have a lot of faith, I think, in the medical teams who see them. So for a lot of our patients, when they talk to their peer group, they know that we treat with hypofractionation. So as far as they're concerned, it's the standard of care. But even when they look in the literature or they look outside of our practice and ask questions, it is, we can convince them. Patients understand that treating cancers in an efficient manner, reducing the number of visits to the department is advantageous. A lot of our patients have to travel, not as far as they have to travel in Sri Lanka, but that's still a burden for them. And they appreciate that having their overall treatment time halved is good. And so I've got to admit, I can't think of any patients who've specifically requested conventional treatment rather than hypofractionation.
Yeah, okay, thank you. If we use hypofractionation in case of infill relapse, would it be more difficult to do re-irradiation?
I think those of you who attended the pre-symposium educational day on Friday will have seen that retreatment is one of the most challenging things that we do, because there is no protocol to follow. It's all about experience and trying to encapsulate the risk and benefit for each individual patient. We often retreat with hypofractionation because I think in the recurrent setting, some of the advantages that we've talked about are even more important. And I don't know if it's any more difficult. I think it's just as challenging often to come up with a suitable dose and fractionation for recurrent cancer with hypofractionation as it is with conventional fractionation.
Okay. 3 more to go. What would be the acceptable gap for hyperfractionated dose, say 55/20 fraction in head and neck cancer recurrence following definitive radiotherapy?
Again, I don't know if we know the definitive answer to that. As with any recurrent carcinoma, the sooner it is after initial treatment, the poorer the prognosis. So I think if we were going to try and go for a cure rather than for high dose palliation, then normally somewhere in the order of about 2 years between retreats is what we'd probably go for.
Okay. START EB trials included T1 to T3 in not in 1 patients, so it is recommended to use hyperfractionation in more advanced lesions. Is it recommended to use hypofractionation if treating axilla in breast cancer patients?
Yes, we do use hypofractionation when treating axillary disease. Again, we take the protocol from the START trial and use it accordingly. And again, we haven't seen any excess toxicity. If colleagues are concerned about brachial plexus toxicity, then that isn't a problem that we've had.
Okay, that's
one
Dr.
question.
Kumar want to ask question.
Thing is there any effect of dose rate in hypofractionated thing? Because when you increase the dose rate, the tumor control, what about that?
So dose rate as in brachytherapy or dose rate?
Because sometimes we use FFF for the SBRT, flattening filter-free beam or true beam. Similarly, because we are not setting the dose rates when we are planning, we have the option in the planning setup. If we increase the dose rate has effect on radiobiological effect with a more tumor response.
So absolutely. So I guess it's a theoretical concept that we're looking at, and we mostly see the effect of dose rate when we compare brachytherapy to external beam radiotherapy. I think in external beam radiotherapy, even though we have flattening filter-free machines nowadays, I don't think that we have actually practically seen that effect of dose rate in patients. The big advantage of using FFF machines is that it shortens the treatment time. So for example, if we're giving SABR on a cyber knife versus a standard Linac with FFF, then obviously we can give saber much quicker. We don't need to be so worried about motion management and tracking because we're giving it in a matter of minutes. And that's, I think, is the advantage of using that technology. I don't think we're in a place where we can be so refined with our radiobiology that we can actually say that there's an advantage to the dose rate using photons in that way.
Last question, that is in a hypoxic setting, when you are giving hypofractionated schedule in a shortened period, shortened number of fractions, are you not allowing the tumor to get reoxygenated? Because reoxygenation effect, whether are we blocking?
So I think that's a very interesting question. And I don't think that we have the again, the detail to be able to know for sure. But for example, if we look at the bladder cancer data, then the effect of hypofractionation was superior for local control in radiotherapy alone, in radiotherapy given with chemotherapy, so in the case of bladder, mitomycin C and 5-FU, but also in the radiotherapy given with hypoxia modification. So across all three different groups, there was an advantage to 55 Gray in 20 fractions over 64 Gray in 32 fractions. And so that suggests, certainly in the case of bladder cancer, that compared to things like reassortment or radiosensitivity, that it may be that repopulation is the most important factor there radiobiologically. Who knows, these models are really difficult, I think, to take from the bench side into the clinic. And therefore, all we can do is go from the clinical data that we have.
Okay, thank you so much, Ananya. Thank you very much for your very excellent presentation and answering all our questions, burning questions. And we would like to see you in physically next year. Hope and wish we will meet you up next year in our college sessions. So thank you so much for being with us.
Thank you so much, and hope everybody stays safe.